Good morning. Thank you very much for the opportunity to speak to you, and I hope that I can be informative. I think we will have time for questions perhaps at the end of this, but we will also have time for questions at multiple times through the day. So please do feel free to interrupt me if you would like, but I think we'll also make some time for you a little bit later. So my task today is to talk to you about atypical aHUS, obviously, but more importantly, what I'm supposed to talk to you about is exactly what is atypical aHUS. And I think that that's a difficult task for physicians, for families, for children, for sure. So the objectives today are to review the definition as best as we know it, describe some of the confusion surrounding the diagnosis, and actually maybe bring up a little bit of those myths that Bill talked about a few moments ago, and then very briefly talk about the complement cascade, because others that will be presenting this morning, I think, will get into that with a bit more detail. So what is atypical aHUS? I think most of you obviously know this, but we put as many qualifiers on this disease as we can. It's rare, it's chronic, it can be absolutely life-threatening for some children, and it is, now we know, complement-mediated, and of course it's systemic, meaning it's going to affect many parts of the body. What is the incidence, or what is the number of new cases per year? We frankly probably don't know exactly, but at best guess it's probably 1 to 3 million population, and the prevalence is completely unknown at this point because we're discovering more and more cases, if you will, but we don't know how many are still out there that we haven't been able to find out. Affects both adults and children. This is one of those myths. I think in general most of us believe that it probably affects the majority. For the majority it is in children, but in the studies that have been reported, there may be even as many as 41% of those that are reported that are actually adults. So it does affect adults, as some of our families know. So what is it? Well, it's as its name says, aHUS. The first component of that is actually this hemolytic component, if you will, and hemolytic anemia and thrombocytopenia are the key components of the hemolysis, or the key component of the hemolytic part of this disease. And in that, we generally will talk about it being a hemoglobin of less than 10. It may be a little bit higher, maybe a little bit lower. In general, we're talking about an LDH, or a lactic acid dehydrogenase, in case you ever wanted to know what LDH meant, is greater than the upper limits of normals. For some children it can be very high, others it can be just above normal. We're also talking about this thing we call a low haptoglobin. We talk about schistocytes, and actually I thought I would, it's bandied around a lot, this thing we call schistocytes, but this is actually what that is. Normally a red cell should be this nice round pink thing, basically. When we're talking about schistocytes, we're talking about these little blobs of things that are completely abnormal in shape, and that's very characteristic for physicians to be able to look under the microscope and find these. So we know that schistocytes are present in this disease. And finally, this is a small point that's probably not so important to you, but it really is a Coombs negative hemolytic anemia, and that separates it from some of the other diseases. And that is very important for the physicians. And finally, we will in general talk about it needing to have a platelet count of less than 150,000. Many of you probably know exactly what your children's platelet count was on the day they presented, and you probably know exactly what it's been every day since. So we start with that less than 150, but we know that there's a huge variation in there. Finally, the U of the aHUS is renal impairment, and in fact, that really just means an abnormal creatinine. And that's also a number that I'm sure that very many of you will watch. So we have that sort of clinical presentation, and most physicians will be able to identify that, but there is also a biopsy presentation of this disease, and it can in some ways trump the clinical presentation. And the example I will offer is if the platelets are not quite right, or if the LDH is not quite right, but if you do a biopsy and you find this thing we call a thrombotic microangiopathy, then you also at least have to entertain the idea of whether it's an atypical aHUS. This particular picture I show you is actually one of our patients, and what I would like to sort of indicate is that I know this just looks like a bunch of pink stuff to you, but this is a blood vessel here. And notice there should be a nice open area where in fact blood can flow. Unfortunately, what happens in atypical aHUS patients is it looks like this. So what happens is that blood that was flowing through there can no longer flow, and instead you've got these red cells that are stuck inside the lining of the blood cell, and particularly there may be just a frank clot there. just a collection of platelets and red blood cells that then stops flow. And that is actually, obviously a very worrisome process, but this is actually something that can be found fairly frequently in this disease. We don't always biopsy, obviously, but if you do biopsy, you might find this thing called thrombotic microangiopathy. So I've given you a basic idea of what the disease is. So you might say to me, well, so what's the problem? Why can't we identify it? Well, this slide is my prelude for the next slide. And let me just start with saying that, first of all, in order to diagnose it in any of our children or any of our adults, someone has to be thinking it's possible. If the words atypical aHUS don't pop into their brain, they may not even in fact think about it for a part of the diagnosis. The second thing is that that list of hematologic parameters that I gave you, those are very sort of nonspecific, if you will. There's going to be a lot of diseases, unfortunately, that do have those presentations. Maybe some of them, maybe all of them, but the bottom line is that it's not completely clear-cut whether you are dealing with atypical aHUS when the patient first presents. And in fact, it's made worse by the last bullet here. We don't have a good diagnostic test. It's not like I can say, this test is positive, therefore it is 100% sure that you have atypical aHUS. We just don't have that. And why is that important? Because of this. It's alphabet soup, right? But unfortunately, physicians face this every day. When a patient presents with those hematologic parameters, absolutely each one of these diseases could be the actual cause of that. And I don't need to tell you all of these, but this is thrombotic thrombocytopenia purpura. This is the diarrhea positive aHUS or the typical aHUS. This is, let's see, this is acute kidney injury. Even some patients with acute kidney injury can have some low platelets and anemia. So are we talking about atypical aHUS? So you can see a physician who's facing that particular group of hematologic parameters is really stuck because they really have to have a very high index of suspicion to take it higher. And what often will get in our way are these two particular diseases. So in fact, I think most of us are pretty comfortable when we're talking about diarrhea positive or the endemic form or the infectious form of aHUS. Most of us can understand that. But when we get to this other one, thrombocytopenia purpura, TTP, then it gets a little bit fuzzier, and I'm going to try to present a little bit of a schematic for you that might make you understand a little bit why it can be fuzzy for physicians. A little bit of definitions just about those three particular diseases because they're often sort of mixed up in this confusion that a physician may have when they're trying to diagnose the disease. Again, typical aHUS, it is common. It is the most common form of the aHUSs, and it counts for about 90% of those cases. And you know, those of you who live in farming communities probably know there's an outbreak every so often. Though we don't have any German families here, of course, today, but the German people obviously know this disease very well. This is what caused this huge outbreak in Germany just recently. So, but they're really, I think. Classically in children, we like to say that this is a self-limiting disease. So this disease will come, it will run its course. The children may end up in the end with a small degree of kidney dysfunction or maybe some high blood pressure. But as you in this room know, those are small problems compared to what children with atypical aHUS or adults with atypical aHUS can face. Then the other entity, thrombotic thrombocytopenia purpura, is, frankly, it's an abnormality of this particular protein called ADAMTS-13. And I'm going to give you a pictorial of this, but the bottom line is that protein doesn't function, so you get the same hematologic parameters that we talked about with atypical aHUS. Also a very rare disease, probably occurs more in adults than it does in children, so it may be a little bit of the adverse to what we're dealing with atypical aHUS. And then finally we get to atypical aHUS. It accounts for about 10% of all those aHUS cases. There is generally no evidence of obvious infection, though, as many of you will say, is that there's maybe a prodrome of some kind, a little bit of fatigue, a little bit of flu-type symptoms, but no one. Often you can't put a finger on infection, but particularly you shouldn't be able to put a finger on the infection that usually causes the typical form of aHUS. But I will admit, quite frankly, even these boundaries are being blurred very, very much in recent months. Lost my screen. So And in fact, we classically say that atypical aHUS is not associated with diarrhea, but I will tell you that there are clearly identified cases where children have had their first episode of atypical aHUS in a setting where they've had a diarrheal illness. So here's my schematic that I've tried to draw for you. So on this side, we have the typical aHUS form. And the bottom line here really is you have this toxin that is taken in by mouth, and it damages the endothelium. Pretend this is a blood vessel. You damage the endothelium. You get this clump of platelets. It's as simple as that. Clump of platelets means you're going to have trouble with blood flow. These red cells that should be able to just race by end up being broken up in small pieces. Hence, you get the schistocytes. So that's in typical aHUS. In TTP, on the other hand, I mentioned to you these very long von Willebrand factor multimers, we call them. They don't get broken up like they're supposed to. So they are hanging in the blood vessel inappropriately, if you will, and they're beginning to snag these platelets. And again, red cells that should just be sliding right through there are now being chopped up by the platelets and by this conglomeration of abnormal protein. And then finally, we have the form of atypical aHUS, which I won't spend a lot of time going through. I have depicted so that you can see that there obviously are lots of complement components here. You do eventually get the endothelia or the blood vessel rupture or damage, if you will. And then again, same concept. You get a group of platelets being collected. Blood that is trying to flow through that blood vessel is then inhibited, or is damaged when it's trying to go through, and you get the same picture. You get schistocytes. So you can see, again, it's a very similar process happening in all three diseases with respect to what's happening to the blood, whether you're getting clot formation, whether you're damaging red blood cells. So we've talked about as best as we can, the definition of the disease. The next thing that I should talk about, because you're going to get more about, in subsequent lectures, you're going to get more about the therapy and the genetics of this disease. My role should really be to talk to you a little bit more about exactly how this disease presents or how this disease affects patients. And the bottom line is, as this slide depicts, it's a multi-organ disease. There's a lot of people that perhaps thought because of its name, aHUS, it only affected the kidney. I don't have to tell the people in this room that that's obviously not true. We affect all of these organs. The brain, the heart, the kidney, the GI tract, certainly the lungs and the pancreas also can potentially be affected in this disease. As best as we know, the kidneys are affected in 50 to 90% of children or in patients. And it is unfortunate that we have to leave that wide range of 50 to 90%, but that really is as best as we know. Obviously, as a nephrologist, I see plenty of children with atypical aHUS have their kidney affected, and I would say I'm probably on the 90% end. But I do, obviously, many of you will know it affects the kidney. It also affects the brain. There's certainly, and unfortunately, you're noticing that wide percentage out there also. But we can see stroke, we can see seizure, we can see fluctuating consciousness. There are lots of symptoms that actually can be attributed to this disease in both adults and children. Up to 43% of patients can have some cardiac effect. Many times this is severe hypertension. That's probably one of the #1 findings. But there also can be children that can get cardiomyopathy and myocarditis and a number of other cardiac-associated abnormalities that really become, a whole set of problems, if you will, that a physician must address that is independent of that hemolytic uremic component, if you will. Then there are 14 to 20% of children that have the GI tract that affected. Certainly I have seen pancreatitis happen in this setting, and you can actually even develop diabetes in this setting. And finally, it has been reported that pulmonary hemorrhage can occur in these children, and those of you who have had children or yourselves have been on dialysis, you certainly know that pulmonary edema or fluid in the lung spaces is very definitely a risk for this population. So what we see as a physician is we see a patient who presents with fatigue, maybe they're a little bit confused or crankier than they usually are. In their blood labs, we notice that they have low platelets, high LDH, and anemia perhaps in the blood labs. And certainly, as I mentioned to you, we very often will see that elevated creatinine. And then mom and dad say, well, in the last several, weeks they've been throwing up more than they usually do, or maybe they're puffier, and maybe they've had diarrhea. Unfortunately, though, that's not all that's there. What the physician has to do is take it the next step and try to figure out exactly what else could be happening and what other special therapies would be required. Because as you can see, below the waterline in this depiction is a lot of very serious medical issues that we find sometimes need very urgent care, sometimes need ICU care. So it's not just what we're seeing in the laboratory values or what's being reported in a simple day-to-day life for these patients. So what do we know so far? That it can have devastating outcomes. Bill talked about, we have had families who have lost their children. We've had families who still struggle in hospitals even today trying to get on top of this disease. Why is it such a problem for physicians? Obviously because of the burden of that to the families and everyone involved in the care of a patient. But also it's a problem because we don't have these clear distinctions between this disease and the other diseases that I talked about. But what we do know now, which is something we didn't know not so very long ago, and I'll give you a timeline here, what we do know now is that atypical aHUS is a chronic disease and it is driven by uncontrolled complement. That's obviously very important that we now know that. When we didn't know that, we wouldn't have known whether Solaris would work for us. Here's the timeline, if you will, that sort of gives us an idea that already by 1973 we were starting to understand that complement was involved in this disease. But over the subsequent years, we discovered many of the other components of the complement system were very suspect and were beginning to sort of come to the top, if you will, as playing a role in this disease. And you'll notice that as we get later in the years, we're discovering more and more. Obviously, this is what we all hope for. This is what Richard's lab is ultimately, incredibly useful and is doing on a daily basis, if you will. We don't know what's going to happen in 2011, but I can assure you that something is happening in 2011 that will contribute to this disease. I won't spend a lot of time on the complement system because even medical students, physicians, nursing, everyone hates the complement system. It's one of those things that has a lot of letters and a lot of alphabet in it, and it's not really terribly important that we spend a lot of time on it, except to know that we've already indicated that some of these genes that have been identified as being involved in this disease are in the alternate complement pathway. And the alternate complement pathway goes this way, if you will. So it comes down through all of these various proteins to get to this endpoint where we call a membrane attack complex, which certainly can damage the membrane of a bacteria, but it can also damage membranes of human cells and can also lead to a lot of inflammatory problems, etc. But for our purposes, what I just want to focus on very briefly is that there should be some breaks in this system, and you probably recognize some of the names. We have complement factor H here, we have MCP, we have factor I. Those are breaks for this system that in this particular disease, atypical aHUS, that we have some abnormalities in, and this is what Richard's lab has been so very good at helping point out, is that these proteins are abnormal. These are the genetics of atypical aHUS, and this is what we hope for the future, that we will continue finding other proteins, other genes in this pathway. In fact, I think Richard's going to talk a little bit more about that, other genes in this pathway that may be playing a role in this disease. Why is it even important? Because already we know, based on what we know about the genetics, we know how an individual patient might respond to plasma exchange. We know how that individual might respond to transplant, recurrence of disease even in native kidneys. So absolutely the genetics are helpful in this setting. We can know more about this disease. I've already told you right now it's very difficult to diagnose it. It would really be nice if it were very easy to tell you what it was based on its genetics. Unfortunately, there's probably about 50 to 70% of patients that we're able to identify the genetics in right now, so we don't know what the rest of the story is. It doesn't mean that they don't have atypical aHUS. I suspect that there are families in this room who have children. In fact, I know there are. who have children who don't have an identifiable genetic abnormality. That doesn't change the fact that they have atypical aHUS for us. That just makes us more interested in pushing to find out what that is. And particularly, this is kind of one of those things that we talk to other physicians about, if you will. The genetics are not important to making the diagnosis right now in terms of treating that child that's in the ICU or that's in the clinic setting right now. The genetics are not important to making the decision to start initial therapy. The genetics are going to be much more important for a lot of other reasons, which we'll talk about in the rest of the sessions today. But the point is that there are absolutely children who do not have an identifiable genetic mutation, but they still have atypical aHUS. And even if they have unfortunately, even if there are, in some patients, if we have an identified genetic mutation, we don't have disease because of this last point here, the penetrance. And that's just basically, that's our term that we use for the fact that only 50% of those, as best as we know, and again, you keep hearing me say that, I'm sure, but as best as we know about those, even if you have the gene and you have only potentially a 50% chance of actually manifesting disease. Now, of course, it depends on the gene, et cetera. There's a lot of things that actually will qualify that. So don't hold me to that 50% too tightly. But the point is that not everyone with a mutation will get disease. So what do we know about atypical aHUS based on the genetics is that while mutations are very informative, currently, right now, they do give some prognostic indication, but as everyone in this room knows, all patients with atypical aHUS tend to have a different presentation. Or at least that's what we have right now, because we have one report here and one report here. Everyone presents very differently. So I'm getting close to the end of my slide, so what I'll just very quickly say is that what do we know about about atypical aHUS right now is that it's a genetic or acquired inability to regulate complement. And when we say acquired, we're usually talking about the autoantibodies that develop in this disease. That's really the population I'm talking about there. But it does give the patient a lifelong risk for having these exacerbations that we know happen. It's chronic and it's uncontrolled complement activation. We know that from that list of genetic research that historically that I've presented to you. We also know that it involves one of those pathways that I showed you in that cartoon, that it's a systemic thrombotic microangiopathy. And what that really means is that small blood vessels will have blood clots in them, and the patients will be inflamed, and they will have, because of the clots that are present in the blood vessels, they will have difficulty with blood flow to various organs, whether that organ is the kidney or the brain, whatever that organ is. That's one of the major features of this disease. But we also know that there are subclinical disease. There are times when there is obvious clinical presentations. There are times when there's multi-organ dysfunction and even, unfortunately, death. But there are also times when we're just impairing the quality of life because of how difficult this disease is to first of all, diagnose, of course, but also to treat and to stay on top of. Obviously, in our second lecture, a couple lectures from now, we'll talk about how perhaps it won't be as hard to stay on top of in the future because of our wonderful drug Solaris, but there's a constellation of problems for these patients that are not only medical problems, if you will. So this is what we had until just recently. We had atypical aHUS, which is a life-threatening disease, and obviously it is still a life-threatening disease, but I'd like to say that, so here's the statistics for you. Short term, up to 60% of patients had an incidence, 60% incidence of end-stage renal disease or death. That's the first event. Over the longer term, and that's basically over a 3-year period, these particular authors were reporting, there was up to a 77% incidence of end-stage or death. That's bad, right? What we hope for, obviously, is in the future that it's not that bad, and already in our practices we're seeing that it is not that bad, that we are making a big difference in this disease by early identification, early interventions, whether they be better blood pressure control, et cetera, but absolutely, most definitely, with the use of Solaris, we're seeing a difference. And there's many of you in this room that already know that. So from a standpoint of talking about what is atypical aHUS, since that was my task today, I've sort of listed a few future directions on here similar to what Bill had done, because it's what's important to generate thought, if you will, in this particular category of the presentation. And the first one is that we need better phenotyping, and that's our scientific term, if you will. We need to know how many children have heart failure, how many children have stroke, how many are having pancreatitis, and are they at a different age when they have pancreatitis, or are they at a different age when they're having their neuropathy, etc. We need better phenotypic information, and through this we can make better use of our genotyping information, which obviously is the underpinning of everything that we'll know about this disease in the future. We need a better way to surveil these patients. From a physician standpoint, from what I know about this disease, I would really like to know from a day-to-day basis, how can I tell whether my child has active disease, doesn't have active disease? Now, obviously, I can make some guesses at this, but I would like your facts. I would like some sort of hard evidence or some biomarker, something that would tell me whether I have a patient in front of me who is improving or not improving. Sometimes it's not as easy as what is the platelet count doing right now. Finally, obviously, Iowa has made a commitment to try to help other physicians understand atypical aHUS, and that's what I mean by access. Access to understanding disease, access to advice about how to treat it, access, any kind of access that helps patients is what we're interested in doing here. And finally, obviously, as you know, and you're going to get more talk about this, gene discovery. It needs to happen. We need to know more about this disease, because if we collect better phenotypes, if we don't have the genotypes, it's not going to be as useful. And finally, any ongoing research in this area is much appreciated as far as those of us who are clinicians in this disease are concerned.